All right, we'll talk real quickly about patient radiation protection concepts, which is a large part of what's dealt with in radiation protection. So really the last lecture was there to provide some context, because I didn't require reading related to that material. I want to just touch on some important concepts for why we need to protect both the patients and ourselves from radiation to as much as possible. In general, though, the things that we're going to be thinking about as ways to protect the patient are going to be communication styles, immobilization shielding, exposure factors, repeat images, unnecessary procedures, amounts of radiation, controlling them, the ethics, concerns specific to the pregnant patient. And I can't see, what's the last thing on the slide? Do y'all know?
Pediatric imaging.
It's pediatric stuff. Okay. So communication. I like to have little recipes in the back of my mind, and I pretty much communicate with patients consistently throughout. Not that like I want to be redundant or anything like that, but I do want to have just enough small talk with the patient to put them at ease and let them know that I'm trustworthy, but at the same time I have some key questions I need to ask them, right? So within basically a minute of meeting young females, I've got to ask them about their last menstrual period, right? I've got to ask if they're sexually active or if they could be pregnant, things like that, particularly when we were working in computed tomography. So I had to do a little bit of something to make sure that they're going to be comfortable with me, that I'm not just some kind of crazy sociopath who sits around asking people weird questions, right? So AIDIT is very helpful because it does allow us to kind of acknowledge and introduce ourselves. It just constantly reminds us, so I don't have to be thinking about that when I really need to be thinking about how best to minimize patient dose. BERT is another thing that can be very, 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 very helpful to patients, and I can't stress it enough. If you have a patient who asks you questions about radiation exposure or the safety of the examination, background equivalent radiation time is what BERT stands for, background equivalent radiation time. And it's a way of equating these weird dosage amounts to a unit that patients can understand. So rather than say that, well, you're fine because today's exam only takes 0.05 centigrades of exposure, which means nothing to them, you can say, well, did you know that radiation is part of the natural environment? The background radiation is about 3 gray every year, right? This exposure that you're going to receive today is about 2 weeks of natural background radiation exposure. Right? You can say that with just about any diagnostic x-ray exam and be pretty close to the money, right? So that number, again, is for a diagnostic chest x-ray, 2-view chest x-ray. One way that I could talk about is I could say, the patient's concerned about the radiation from the chest x-ray, I could say, it's about equal to 10 days of natural background radiation. 10 days or 2 weeks natural background radiation. The other way I could talk about it is I could say, you know that radiation is naturally occurring, it's around us all the time. The exposure that you're going to receive today is about the same as a flight to Paris, right? You would also receive the same amount of radiation flying to Paris. And who doesn't want to go to Paris, right? So these are just ways to put radiation exposure in ways that in a communication style that the patient understands, and to equate it back to stuff that makes sense to them, and to inform them that radiation is a naturally occurring part of the environment, right? ALARA is an important thing to communicate to the patient as well. Today, during this exam, I'm going to keep your radiation dose as low as reasonably achievable. That is our goal here. Saying that word, saying I communicated to the patient that I'm going to keep my exams as low as reasonably achievable, that's become a legally binding term, right? So it's not just some mechanical thing to mention to the patient. It actually has held up in the court of law. When people looked at a technologist and say, were they practicing with beneficence or in negligence? Well, were they practicing ALARA? They actually have asked that question now on the legal record, and so it has legal weight to it to say, I'm keeping your radiation dose as low as reasonably achievable. Finally, trace programs. are those cheesy posters that you see in hospital hallways and elevators, explaining in some way, shape, or form something that's relatable to the patient. Did you ask your technologist about pregnancy? Right? Those kinds of posters largely come out of TRACE programs. And they're just yet another way to communicate with patients. Another thing that can come out of TRACE programs, I don't think there's any facilities that are doing this right now, but is pamphlets that explain to people the risk and the exposure that they'll receive from an examination. In general, written language is going to make a lot more sense to patients because they are stressed through the roof by stuff that has nothing to do with the x-ray that they're getting. It has to do with what's the x-ray going to show, right? So if I come into the patient's room and start explaining about the dose related to CT examination and how significant that dose is and it can cause hematologic depression, I am talking like that teacher on Charlie Brown. All they're hearing is wah, 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 right? Like they're worried about like, do I have a blood clot in my lungs? Is this going to kill me today? So giving it the information in as many ways as possible and communicating in a written form is definitely recommended. In fact, repeated radiation exposures a lot of times are in some way attributed to poor communication. So if you have a situation where you've had to repeat an examination, it's definitely good to think about what part of your procedure and your positioning was inappropriate, but maybe also wonder, was there something that I should have communicated better with the patient? Did they understand the breathing instructions? Was I communicating in a way with this patient who was combative that helped ease them and make them more compliant with the instruction? So, two types of patient motion: the voluntary type and the involuntary type. Voluntary type of motion is a person just moves, right? They didn't understand the instructions or whatever, they moved. Involuntary is stuff like peristalsis, heart rate. Every chest x-ray you ever take is going to have motion on it from the heart, right? So we have to, the way that we will minimize both of these is largely the same: reduce exposure time, right? Increase MA, decrease time, and keep the exposure time short. Shielding. When at all possible, we will shield these areas of the body. Whenever they are within 5 centimeters of the primary beam, okay? That's kind of a good rule of thumb for us. So if the family jewels are within 5 centimeters of the primary beam, shielding is strongly recommended. The way that I explain this to the patient is I'm going to shield, and I typically say, your family jewels from the radiation. I'm trying to keep your dose as low as reasonably achievable. That's literally the words that I say to every patient. I tell them what I'm doing and why. If they ask me, well, why is that important? Then I can go into my BERT explanation that, you know, radiation's naturally occurring in the background. The exam today takes it's about equal to 10 days of exposure to just naturally occurring radiation, but it's best if we keep that from potentially affecting future generations. These other areas of the body, like we've already mentioned, are very radiosensitive, and they're kind of the top three. Mammary tissue, thyroid tissue, and the lens of the eyes are areas of significant concern. So types of shields that we use: flat contact, which is probably what we're most often using. This is even those shields that we slide up behind patients would be considered a flat contact shield. Shadow shielding we generally use in fluoroscopy. It's a detachable shield that kind of hovers above the patient, and they can position it without affecting sterile draping. Shaped contact shields, the only time I've ever seen those used was in radiation therapy, and these would be something that follow the contour typically of the male gonads in order to shield that area. And then clear lead shields, this is what we're using with our glasses and with the windows and stuff in our, as well as the Pyrex type stuff that we use in the OR. I would say in addition to that, you can also use the patient's body as a shield. And so whenever we do a PA chest x-ray, we're essentially using the patient's body to shield both the mammary tissue and the thyroid glands, because we're just turning them towards away from the primary beam. So again, gonadal shielding should be used when these organs are within 5 cm of the beam. Are any of the facilities that you're at using shielding on female patients for pelvises or abdomens or anything like that? You've seen pelvic shielding? That's good. For female patients, the shield must be placed approximately 2.5 centimeters medial to each palpable as is, right? So the front part of your pelvis, there's that little spine. If you move medially about 1 inch, that's where you want to place the tiny little shields like this in order to shield the ovaries. Most facilities I worked at have not asked us to do that because they're concerned about underlying bony anatomy or something like that being missed. Shielding for kids. If the gonadal tissue is more than 2 centimeters from the edge of the field, doesn't necessarily help. Now, I would still shield kids, but kids are much smaller than us in general. And so the primary form of a gonadal dose that kids receive is from internal scatter radiation, so from their own body, and there's no way to shield that. What I'm saying is, on those NICU patients, one thing that we have to think about is my machine is filthy and these shields are filthy. Which is more significant to this child? The radiation dose or potential disease being introduced to this incubator? So in general, the way that I've shielded pediatric patients, and also the things are moving all over the place and you're trying to get a picture and it's hard, right? And the nurses are mad at you because what they don't tell you is that all NICU nurses are mad all the time, right? With good reason. So shadow shield if necessary, but largely shielding is not as helpful with those little kids, right? Shield it if you can. If you can't, don't lose any sleep over it is what I'm saying. Most of that dose is going to come from internal scatter. Now, if you're right on top of those gonads, then sure, go ahead and shield. Exposure factors. There's a lot of things that we can do at the control console to reduce the patient's radiation dose. And I think that maybe this didn't transcribe right. Let me see. This should be mass like milliampere seconds. As we decrease the mass, we are decreasing patient dose. They are directly related. So anytime we have an opportunity to decrease mass, we can decrease patient dose. That's one of the primary ways that we can work to reduce patient dose. Anytime we are increasing the effective atomic number of the tissue, we are increasing patient exposure. When do we do that? Well, anytime we use contrast, and we'll get into that some next week when we talk about contrast, but barium, iodide, all those things increase atomic number of things like blood, the blood and bowel and things like that. They are also increasing patient dose. There's actually increasing scatter events caused by the iodine and the barium. Film screen is largely obsolete, but it still relates to speed of detector. So we could actually be using faster detector speeds. This is probably a major issue for us, and we don't even realize it. When most of our CR and DR systems are installed, they're installed at about a 200 speed film. We can increase that film speed and reduce patient dose. What we would lose would be some spatial resolution. So something to think about once you get to management. Source to skin distance, if we increase source to skin distance, we reduce patient dose. And so there's been suggestions in some of the literature of having even larger source to skin distances in the future. The type of filtration that we use. The primary reason that we filter the primary beam is to reduce patient skin exposure. So as we increase filtration, we in general are reducing patient dose. And then using high-frequency generators are going to be better than using old-school equipment. So even though I like the honeymoon suite, even though I like the small room over there for teaching, it's not the room that I would want to get an x-ray in because it's an older generator and it's going to expose me to more radiation. So, one thing that we found, and this has largely already been incorporated into your Merrills, and so the numbers that you're memorizing are already holding true to this, but we call it the 15% rule. We can increase the KVP by 15% and reduce the mass, and that, again, that should be mass, M-A-S, by half. It's the 15% rule. We'll be talking about it a lot more in image eval, but we can increase the KVP by 15% and decrease the mass by half, and thereby reduce patient exposure. And as we all know, the next part is kind of obsolete. Repeat images. I think it's an awesome idea to have a repeat analysis program. Baptist does not currently have one. And so some of the things that we see in the culture at our clinical sites, in my opinion, reflects that bad policy. But repeat analysis is done by a technologist, generally sometimes working alongside a radiologist, and they're saying, why did we repeat these images? What was the error? Is there a common set of errors that we're seeing happen in our department? Is there education or something that we can do to improve our X-ray imaging? The place that I was at, a clinical site at McKay-Dee in Ogden, Utah, they had an amazing repeat analysis program. It was the thing I hated the most about my clinical experience, was they required students to be at monthly staff meetings for the repeat analysis part, because it was incredibly valuable. But a lot of times it was our initials that was up there, and everyone was looking at our image and saying, boy, that's a lordotic chest. And Benny shot that, right? But I learned more through that than just about anything else. We don't currently have that in our company. Unnecessary procedures. So here's a Consumer Reports study saying that a lot of these CTs and X-rays that are being ordered are not necessary. This is probably a big, if you ever wind up at some of these smaller clinics or smaller ERs, some of these physicians are just kind of ordering things CYA, and we know what that means, right? It's probably one of the #1 complaints that I see on GroupMe from graduated classes is that these doctors at X facility keep ordering this CT brain stuff or whatever needlessly, right? Now, whether or not it's needful is not always up to the technologist to determine, right? But I would encourage you to work closely with ordering physicians, requesting physicians, and say, hey, I saw we did this, you've got this order of this barium double contrast study on this young female. Have we done an ultrasound yet? Or talk to the radiologist. Look, I got this order for this patient. Is this something we really need to be doing, or is there a better exam that we could be doing? So we'll look at that more as we go through y'all's time here. Amounts of radiation. Whenever we're thinking about what the irradiation was, the 3 ways that we have of quantifying it are entrance skin exposure, bone marrow dose, and gonadal dose. So if we, for example, we call Mr. Smith out of the lobby, and Mr. Jones stands up, and we do Mr. Smith's x-ray on Mr. Jones, we just have a problem in that we've unnecessarily irradiated Mr. Jones, right? So the physicist is going to have to be called in and determine what would be these exposures, what would be these doses, and this is the way that they're going to break it down as an entrance skin exposure, bone marrow dose, and gonadal dose. But we use these in all sorts of calculations. Ethics. The things that I have seen that are of most concern to me in terms of what y'all are exposed to in the clinic ethically when it comes to patient radiation safety, the #1 is fluoroscopy guided positioning. If you look at the ASRT and the ARRT, they both prohibit it. They say it's not within our professional scope of practice to use the fluoroscope to guide us and make sure that we are in a proper alignment to take an x-ray. We are supposed to use our imagination and intelligence to position the patient to acquire images. Does that make sense? Makes sense to me. But there's some of the technologists that we're seeing out in the field that are using the fluoroscope in order to line up for routine x-rays. I don't want to say that's illegal, but I can definitely say that is unprofessional, and outside of our scope of practice. If there are any questions about that, you're going to see it, and it is borderline illegal. The ways that I would respond to that are through continuing education and training. Unfortunately, historically, our profession has been fairly unprofessional in its attitudes towards education and training, and so that has been impactful long-term in terms of patients' radiation safety. A quality control program, a repeat analysis, is a great way to educate technologists in a way that's meaningful. That does require some additional money and policies that support that program, but I think it winds up saving money in the long term. Standardized technique charts, so having technique charts that accurately reflect the kinds of radiation the equipment's being produced is probably one of the best ways that we have at our disposal to make sure, especially during portable imaging, that we're doing things appropriately. And then the repeat analysis program. Pregnant patients. It is essential that we talk to the patient about whether or not they are pregnant and their last menstrual period. I know that probably not a lot of us are asking the LMP question. It's probably not part of your standard pattern. But if you're doing abdominal imaging or any kind of small bowel follow-through on a patient who's of childbearing age, it is important that we ask that question and document that that question is asked and the date that they stated that their last menstrual period was. It becomes that much more important if we're doing computed tomography examinations. If there's ever a question, any question, if you ask the patient, is there any chance you could be pregnant? And they say, then you just need to get a test done, right? It tacks on maybe 30 minutes, and it could be very, very helpful. I have had patients who were pregnant, and a doctor had ordered a renal stone protocol or whatever, and we did not need to be doing a renal stone protocol. So this is coming from the NCRP, which is the National Council of Radiation Protection and Measurements. Ideally, an elective abdominal exam of women of childbearing age should be performed during the first few days after the onset of menses to minimize the possibility of irradiating an embryo. And that goes back to what we learned earlier about that sensitivity period. If there is an inadvertent irradiation of a pregnant patient, I had a patient once, unfortunately it didn't happen to me, but it happened to a good friend of mine. He was the graveyard tech at a facility. The patient came in trying to cause an abortion with a CT scan, and so she stated no, that she wasn't pregnant. She was pregnant, had the CT scan, and there was the child. Then the medical physicist has to be called in and do things like the entrance skin exposure, gonadal dose, and bone dose both for mother and child, and it's a lot to unpack. There's a lot of dosimetry that has to be done. But what we know is that most of the diagnostic x-ray procedures that we do result in fetal exposures of less than 0.01 gray. The risk of abnormality is incredibly small, right? And the number one shielding factor there at that point is mom, right? And so this would include diagnostic x-ray and CT. So I have done CT scans on pregnant women. They knew the patient was pregnant. They had increased D-dimer and suspected there might be a blood clot. So we were very careful not to scan the fetus if at all possible, but we scanned their lungs to see if there was a blood clot. Because at that point in time, if mom dies of a blood clot, then that affects baby and mom both, right? So there's some considerations we have to make like that. But we do that knowing that mom's going to be a shield and that we keep the dose under 0.01 gray to the fetus, we're fine. So in the event that we do accidentally expose a pregnant patient, we need to document. So fill out an incident form, and the stuff that's important to document in the narrative is the x-ray unit used for the study, so the specific machine used, the number of projections taken, and the images associated with each projection, the technique that we used for each projection, the SID for each projection. Does it have other things in that list? I can't see the bottom. It didn't.
patient's anterior, posterior, or lateral dimensions at the site of each projection.
So go ahead and measure the patient.
Fluoroscopy, irradiation, the appropriate KVP, MA, and especially the duration.
Good. Yeah, if it's fluoro, just note the fluoro time.
For spot films, the number taken, and the technique factors as well as the exposure time.
Good. So here is an example of what that kind of incident form might look like, just with all that data there. Pediatric imaging. What we found from the Radiation Effect Research Foundation is that in utero and early child exposures to x-rays and CT scans and things like that significantly increase the risk of fatal cancer in adulthood. You can look that research up. The risk of radiation-induced leukemia in children after a substantial dose of ionizing radiation is approximately 2 times that of an adult. So kids are more radiosensitive than us. They also live longer than adults, right? So we have to take all of that into consideration anytime we're imaging. 2 things that I would encourage you to think about when it comes to pediatric imaging is the programs that have been created by the American College of Radiology, which are Image Wisely and Image Gently. You can sign up for these programs, and I think they give you a button or something to wear on your lanyard. But Image Wisely is talking about lowering the amount of radiation used in medically necessary procedures. It largely has to do with using fluoroscopy appropriately. And then Imaging Gently is child sizing both KVP and MA, so having separate MA and KVP settings for pediatric examinations. CT scanning only in the indicated area, not using multiphasic CT scans, and using some worksheets maybe to figure out how best to do those images. And that is all for the kids and adults.